Welcome to the BMJ podcast. I'm Cameron Abbasi, Editor-in-Chief of the BMJ. This week, we're looking ahead to a new government, possibly, and a new winter crisis.
If we arrive in the middle of winter and it's as bad as we've seen in previous winters, my first question will be, how much can we realistically do, given that the planning hasn't been good enough? And of course, we'll be holding this government to account on its winter planning. But not holding my breath that this will be any different to any other winter we've seen under the Conservatives.
We'll hear about the Kafkaesque situation of GP unemployment while everyone cries out for more primary care doctors.
And there are specialist registrars in general practice who will complete their training in August this year, and some of them are having difficulty finding anywhere to go to.
And finally, the financial ties of the US Commissioner of Food and Drugs, who runs the FDA, and the industries they are regulating.
9 of the past 10 FDA commissioners went on to work for industry or join a pharmaceutical company board after they left the agency. I mean, that's just it doesn't make sense from a public interest perspective.
But first, it looks like we may have a new government in the UK reasonably soon. If that's the case, Wes Streeting, a Member of Parliament, is likely to be the next Health Secretary. And one of the first problems he'll have on his desk is the NHS crisis and the inevitable challenges that we face each winter. Elisabeth Mahase, our clinical news reporter, asked him how he'll deal with that.
I wanted to ask you about a comment you made last December about the winter crisis. You said the NHS uses it as an excuse to ask for more money. And I think that caused quite a lot of hurt among doctors who were in the midst of a winter crisis and seeing the scale of the issue. And hearing that, I think they took it quite personally, as in maybe you didn't believe how bad the situation was. So I wanted to ask you if you wanted to talk a bit more about what you meant when you said that.
Yeah, I mean,
and if you recognise the hurt.
Yeah, firstly, I mean, I have no doubt about how awful winter feels every year and how much frontline staff dread the onset of winter, knowing what's going to happen, because there is now this sense of almost inevitability that every winter there is a deep crisis and doctors are faced with patients in a state they should never be in, and patients are experiencing those miserable and in some cases unsafe conditions that they should never find themselves in too. I think what I find frustrating is the lack of poor planning ahead of winter. The fact that we now see not just crises at winter but all year round, and that too often, I found in the last 2.5 years, too often the answer that system leaders in the NHS reach to is more money. And I think that, the message I wanted to send, particularly to system leaders, was, not just that the public finances are in a terrible mess under the Conservatives, and so there isn't a huge amount of money around, but also we have to make sure that the money that's going into the NHS is being spent to best effect. And there shouldn't be an assumption that every time the NHS runs into winter, they can point to the pressures and just say, we need more money right now. Because actually what you need to do is to government and the NHS working together, plan ahead of winter. Because I think my other frustration is we see at the peak of winter pressures, money going in far too late to make a real difference. So the money arrives too late, it's not put to good use and effect, so we end up wasting money. And we can't go on like this. I've been trying to condition the system to recognise that if there is a Labour government, we recognise that investment is a challenge, but it will also have to go alongside reform. So I'm not trying to beat up the poor staff who are confronted with those, on the front line, confronted with those terrible winter pressures. Quite the opposite. I want to make sure that when they're working during the peak of winter pressures, they feel like they're working in an environment which is safe for patients and also working to a plan that has been agreed well in advance and not left to spiral to the extent I think we've seen winter after winter.
You could potentially be health secretary this winter. Are you already thinking about that and about the winter crisis that will inevitably come and how you'll handle that?
Yeah, my fear is that if the Prime Minister drags this out and we have a general election in November or December or even January, a Labour government might come in right in the middle of winter when, frankly, it's too late. It's too late to make a real difference in the middle of the winter crisis. I mean, you might be able to do some mitigation, but the planning for winter really needs to be underway now. So, if we're looking at a summer election, one of the first questions I'll be asking the Department of Health and NHS England if I walk through the door on day one is, where are we on winter planning? If we arrive in the middle of winter and it's as bad as we've seen in previous winters, my first question will be, how much can we realistically do given that the planning hasn't been good enough? And of course, we'll be holding this government to account on its winter planning, but not holding my breath that this will be any different to any other winter we've seen under the Conservatives.
But if you do come in midway or just before or during a winter crisis, I assume more money is what you will have to do in the immediacy. And you've talked long term about improving the flow, and that's everything that doctors say. You need to sort out social care, you need to sort out prevention, you need to get patients in and out of hospital as quickly as possible. But this winter, you could potentially be, dropped in the middle of that. Would that mean more funding on the short term?
Well, I think
out in the immediacy.
I think the best thing that the Labour Party can do about this coming winter is to hold this government to account, to make sure that there is proper planning and resourcing for the coming winter. And my frustration has been year after year that health secretaries seem to pop up in the middle of winter to say, how have we ended up in this crisis, rather than acting in advance to prevent it. If there's a summer election and if we're fortunate enough to win, we'll get to work on winter planning straight away. But the question though is down to timing. And one of my frustrations about the delay running into a general election is that every month this government remains in office, we see missed opportunities, bad decisions, and not just a waste of time, but a waste of potential and a waste of money. And so that's one of many reasons why a general election can't come soon enough, as far as I'm concerned.
You talked a little bit about junior doctors during the talk. Will you commit? I know you said you can't commit to 35%, but you can't promise that, at least not right now. But like the Welsh government, would you look to commit to it long term? Pay restoration long term, maybe a multi-year deal, something that you can give junior doctors now that says, we can't do this right now, but we're going to work towards this in the future?
Well, we've got to make sure that the promises we make are promises we can keep. And I think it would be unforgivable, given the way they've been treated, if I was to say in opposition, don't worry, junior doctors, we're going to achieve 35%, and then fail to come through and deliver. And I am just constantly aware of the damage that the Conservatives have done both to the economy and the public finances, and that will take time to recover. I recognise we need to move on pay, and I've said to junior doctors, I recognise the fundamental fairness of the argument that they're making, that pay hasn't kept up in line with inflation, that they are, especially earlier in their careers, really struggling with the cost of living, struggling with rents, feeling like the housing ladder is beyond their reach, and struggling with the cost of living. So I want to do as much as I can, as fast as I can. And would be willing to sort of sit down and talk. I still hold out the last bit of hope that this strike will be resolved before the election. And regardless, we will sit down with junior doctors very early on to talk about how we avoid getting back to a situation where people at the start of their careers who should be really excited about a career in medicine are feeling desperate and hopeless and out in the cold, literally on picket lines, when they should be in theatres, in general practice, in the community, feeling really excited about what their future in medicine has to offer.
So you're saying you understand what they are feeling, but you can't necessarily say anything right now in terms of...
We're definitely not in a position of doing dates and deadlines. We're absolutely willing to sit down and negotiate with junior doctors on pay and wider terms and conditions. But what I'm not willing to do at this stage is to set dates and deadlines, because unless I'm 100% sure I can deliver, I'm not going to make promises that I can't be 100% sure of keeping, because I think that comes back to the point I've been making about the lack of respect this government has shown to the profession. I think telling people one thing before an election with good intentions and then letting them down the other side of the election would definitely be disrespectful and would cause more harm than good.
That's Elisabeth Mahase talking to Wes Streeting, the Shadow Secretary for Health, and the full interview is available on bmj.com. Links are in the podcast notes. Still to come, we'll hear about FDA leaders and their financial links to the industries they regulate. But now, another thing the next government in the UK will have to tackle is patient access to general practice or primary care. One of the key drivers of dissatisfaction with the NHS is the time it takes to get an appointment. And in primary care, that's partly driven by a reduction in the number of full-time equivalent GPs, even while demand increases. We're in the mind-boggling situation where GP practices want to employ more GPs, but we have the prospect of unemployed GPs who want to work. Helen Salisbury, GP and BMJ columnist, has written about this and joins us to explain more.
Hi, Cameron. Yeah, I mean, it's really, really strange. I mean, all the time you hear, we don't have enough GPs, we don't have enough GPs, there aren't enough doctors. And yet, there are now stories coming out that, particularly in the north of England, there are 30, 40 applicants for each job, for ordinary salaried GP posts. And there are specialist registrars in general practice who will complete their training in August this year, and some of them are having difficulty finding anywhere to go to and facing possible unemployment, which is ridiculous, really. So there are doctors who want to work, and there are patients who desperately need doctors, and there's no money to pay them, no posts.
So why do we think this is happening? I mean, it seems absolutely bizarre and unacceptable.
It is very strange, isn't it? I mean, it is, of course, all about money. And it's also all about doctor replacements. So here's an example. Somebody who I did some training with who is completing this summer, applied for a job in which she was asked in the interview whether she would be all right being the only doctor in the branch surgery supervising 4 physician associates. She said no, but you can imagine if there are places who are employing many, many other people to do work that was traditionally done by GPs, then there are fewer posts for GPs. And although those people may not actually have the skills to do that job very well, they do come free to the GP practices, whereas there just isn't the money to employ salaried doctors who aren't paid for. So physician associates and paramedics and physiotherapists and a whole bunch of other people can be paid for out of this scheme called the Additional Roles Reimbursement Scheme, which is money that goes to PCNs, primary care networks, to allow them to, and so these roles, the cost of employing people is reimbursed. That money can't be spent on nurses and it can't be spent on doctors. So there's been a 2% rise in funding for GPs in this current contract, whereas as inflation is well more than that, that's a cut in funding to GP practices. So you can understand that GP practices are thinking, well, we just can't afford any more doctors, but we can have these other roles.
So what you aren't saying is that, that we shouldn't have a multidisciplinary team. I mean, there is the principle of a multidisciplinary team, of course, is sound. The problem is in the balance of doctors and other professionals in primary care.
I think that there's some interesting things. There certainly are roles for people other than GPs in general practices. So, for example, pharmacists are extremely useful in improving the quality of the work that we do in checking prescriptions and a whole lot of reconciliation. Patients come out of hospital on a completely different set of medicines than they went into hospital, and that all needs to be sorted out. And it's fantastic to have pharmacists doing that sort of work. And they can also do some kind of protocolized work when there's a clear, if this, then that, ladders for increasing blood pressure control medicines, that sort of thing. I do have some questions about the roles of physician associates in general practice. I think there is an assistant role that's possible, but not very many of them, and only in a very defined role, again, doing protocolized care. And actually what's happened is, if you look at the contract under which most of them have been hired, it actually stipulates they should be first contact. They should be seeing untriaged patients, seeing all comers, whatever's wrong with them. And actually, they don't have the skills to do that, at least not safely. Or if they are going to do that, they need to be debriefing every single patient with somebody who's qualified, who can then go and see the patient if necessary. And that's not.
But this is creating
more work. I'm absolutely not convinced that physician associates have a role in doing face-to-face work of the sort that they're mostly doing at the moment, because to do it safely, they need so much supervision that it doesn't make it worthwhile.
No. So patients are unhappy. There's increasing demand in primary care, which isn't being met. The gatekeeper function isn't being properly implemented. You're having difficulties with continuity of care. As you say, people are dreaming up these strategies, these approaches. Who is dreaming these up? Because there doesn't seem to be any clinical logic to them other than to make the numbers work.
Yes. I mean, some of the projects that I think they've been turned into pilot projects now of a kind of complete revamping of general practice, so that there will be what are called same-day access hubs. So in any area, there'll be one place where, if you want to be seen on the same day, that's where you go, where you will most likely not see a GP. You'll most likely see another healthcare professional, paramedic, physician associate, whatever, being supervised by a GP. And only if you are deemed to need continuity of care by dint of your age or the number of comorbidities you have or whatever it is, will you get to see your own GP. And so this is a destruction of general practice. And there's all sorts of reasons why it doesn't stand up to scrutiny. There are some basic geographical ones. In lots of areas of the country, it makes no sense to go to somewhere else when your GP is in the same village. But there are also reasons to do with continuity of care. We don't know. We can't say that these people need continuity of care. Lots of people need continuity of care. Lots of young people with, mental health problems or substance abuse problems or long-term conditions need long-term, need a continuity of care, and families need continuity. How do you safeguard at all if you don't see all the members of the same family with their myriad of little minor conditions that actually add up to a picture that says this family is not coping? We really do need proper general practice. And there's also a kind of myth that you can tell from the presenting complaint whether something is minor or serious. Because you might present with a cough, okay, and my job as a GP is to find out whether is that viral pneumonia, or is it, just a cold? Is it lung cancer? It could be anything. If somebody pitches up with tummy pain, you have really no idea until you've done the work, until you've taken an expert history from them, whether this is something you need to be worried about and needs to be followed up. And the idea that you can or should go through various levels of lower skilled people before you actually meet a proper doctor is terribly wasteful.
No,
it just
exactly.
doesn't
So,
work.
the foundation of the NHS is a thriving general practice and thriving primary care. People must be feeling demoralised by this.
I think they are. I think some people think it's all over. It's just gone. That's old fashioned. We just don't do that anymore. I have heard people say, that was general practice from the 60s. It just doesn't happen like that.
But you
anymore.
don't think that, presumably.
I don't think that. No, I think more and more medicine is getting more and more complicated, and actually, we really do need. Our patients need to have experts at the front line. We need to be there, seeing our patients, knowing our patients, helping them through what is an incredibly difficult system to navigate at the moment. They need someone in their corner, and that's their GP. And what is difficult to quite grasp, I think, is how many corners we're still in, if you see what I mean, how many places there are still old-fashioned general practices with personal lists who look after their patients and know the families registered with them, and in how many places it's gone massively corporate. The calls are taken by a call centre. You'll just be added to a list of a doctor if you need to be seen, or maybe not even a doctor, maybe somebody else. But there's no continuity, and nobody knows you. And patients want to be known, most of them.
So we've just heard from Wes Streeting, who's likely to be the next health secretary. Do you think there is more hope in the new government whenever that arrives?
I don't know. I don't know. I hope so. And I hope he has the right advisors. There are also lots of people who want his ear, who have a very different picture of the future or what's right from what I do. I actually have very little faith that involving the private sector is going to help in any way, but clearly that's on his agenda. So, watch this space, really. But I do think there's still all to play for, and we need to make sure that we position ourselves so we can say, yes, but have you thought of this? And yes, we can do this, and we can make it better by doing the other, and try and bring the people who will have some power into
Well, Helen, perhaps
alignment.
The answer is to send Wes Streeting all of the columns you've written for us over the last 2 or 3 years, and that should put him on the right path. Listen, thank you so much for joining us. And you can find links to Helen's this particular column and her previous columns in the podcast notes.
Thank you, Kevin.
Now, the Food and Drug Administration says that it takes conflicts of interests very seriously. But it turns out that financial entanglements with the drug industry are common among its leaders, as Peter Doshi, one of our editors, reports in a new investigation. And Peter joins us on the podcast now. Welcome, Peter.
Hi, good to be here.
So, Peter, tell us why you wrote this story.
Well, I've been interested in the topic of the revolving door for some time. I'm interested in essentially the quality, the credibility of regulatory decision making to make sure that the public can trust in regulatory decision making. And so my piece here kind of probes the revolving door between FDA and pharma, biotech, these industries that FDA is supposed to be regulating. And the piece highlights kind of how just so common these relationships are at the very top of the agency. The number one position, which we call the commissioner, is, I start with this mind-boggling statistic that 9 of the past 10 FDA commissioners went on to work for industry or join a pharmaceutical company board after they left the agency. I mean, that's just it doesn't make sense from a public interest perspective. So that's what the story is about. But that statistic has actually been out there. That's not a new discovery of my piece. My piece really is telling a story most heavily about Margaret Hamburg, this who was the commissioner from 2009 to 2015. And I think you might be wondering, well, that was a long time ago, right? But I was approached and got a tip about information that was really concerning, and information that I found was actually even unknown to people that knew her personally. Um, and that information is that while Hamburg was the commissioner, she was allowed to hold financial interests in an exclusive hedge fund that's managed by her husband's company.
But to be clear, this hedge fund was investing in drug companies and life science companies.
Oh, yes, this hedge fund is known as, again, Renaissance Technologies. It's this famous company. It's one of the biggest, most profitable hedge funds ever. They pioneered this whole type of trading known as quantitative trading, a quant fund. And the quant funds use these statistical models to drive their trading decisions. And so, what the actual fund is invested in is actually a black box. Nobody knows. Right? And
So
so,
sorry, just to hold it there. You might then argue that, well, there's no influence then in that case.
right. So
How does the influence work?
right. So it's very hard to figure out. There's this agency known as the Office of Government Ethics that has to review nominations to major presidential appointees, so like the FDA commissioner. And these relationships that Margaret Hamburg had were declared to the Office of Government Ethics, called OGE. OGE reviewed these and said okay. And so the Wall Street Journal was saying, neither Hamburg or her husband would be in a position to direct their medallion account to the companies that were affected by the FDA as a regulator.
Okay, and was that the case?
Well, it appears that that is the reason that OGE accepted from everything I can see, particularly because that is what Peter Brown, Margaret Hamburg's husband, has said elsewhere. I was able to, confirm that he has made these statements elsewhere. But what is very interesting is it's unclear whether that's actually correct, at least in any kind of general understanding of what no human involvement, except in rare circumstances, would mean. And so, where that comes from is this 2014 Senate investigation that I dig into for the piece, which is looking at the abuse of what they call structured financial products. And Renaissance Technologies and Peter Brown, again, the commissioner's husband, are at the center of this Senate investigation. And so Peter Brown is there in the Senate testifying, and what comes out of it, his testimony, is this acknowledgement that actually Renaissance Technologies' algorithm is not this autonomous thing, completely autonomous, but actually something that has frequent human involvement. And the Senate report, I'll just read for it. It stated that, quote, algorithms were dynamic and had to be updated and adjusted on a regular basis by its programmers.
So, Peter, it took you several months to get to the bottom of this. If you're the Office of Government Ethics, how do you go about untangling these very complex financial interests?
I think in today's day and age, the Office of Government Ethics is going to need, and may already have, some savvy people who understand algorithms better. We're now in the whole AI age where we have to think, are these really algorithms that just are completely neutral and completely objective, these autonomous things? Or are they things that are created by humans and modified by humans? And so I think that the general intuition and sense already might be there to ask questions and push back. And it may not in the future take a Senate investigation to really dig into this and ask questions about the nature of algorithms.
But if you look at it, you said 9 out of 10, 11 out of 10 out of 11 have been involved in a revolving door scenario, have had some kind of financial entanglement that we might consider to be questionable. There's the whole point of having ethical overview or having ethical policies seems to be a thin veneer to excuse practice, which, in fact, if you're heading that kind of organization, isn't it best just to be absolutely clean in the people that you appoint and how they behave and who they go and work for before and after? Well,
Yeah, I agree with you, Cameron. I mean, I think we need people to remember what public service fundamentally is and why it's different from private sector work. I don't think it's as simple as saying, like, hey, no matter where you're coming from, we all are in the business of wanting to improve human health. I think that's a bit too naive here. At the end of the day, first and foremost, industry is about private profit. And that's starkly different from public service, which fundamentally is about service in the public interest. And so I do think that one of the takeaways is we really need better education that starts probably at a young age about the norms here, about what is expected and what public service means. And then I think there's probably a conversation to have about the rules, the procedure side, and what we can do there on that bit. And that's where I'd say, and people I spoke to, point out that the Office of Government Ethics needs some strengthening. They need more transparency. They need more teeth to be able to more strongly enforce their recommendations. They need to start to consider things like insider trading. They think mostly about conflict of interest, and they're actually not one and the same thing.
Yeah.
And so I think that in many ways, what all this story points to is really a need to improve Office of Government Ethics. And I was, interested to find that there actually has been legislation that was introduced to do that. And so it would be good if those efforts get some more attention to see, to people understand the urgency of doing that.
Well, hopefully your piece will do that. But it seems quite remarkable that the US couldn't find 9 or 10 people who didn't have these financial entanglements to run the FDA. I mean, either everybody's got financial entanglements. I guess a lot of people do have them, but there must be some very good people who don't have them and could have done a very good job. And then you wouldn't have this impression of bias and industry influence that I think isn't good for the public, but also damages the perception of the whole process.
Right. And to get those kinds of reforms in place, what we need is better leadership from the top, because the commissionership of the FDA and the heads of all of our executive branch agencies are presidential appointees, and so we need a president that sees it that clearly about what public service means and looks for someone who's really a dedicated, devoted public servant, and nominates them, because the Senate can only do so much in terms of evaluating the people in front of them. But they have to get the right person.
I mean, because the heart of it is that if you're really bothered about the public and population health and people's outcomes, then bias and influence, all the evidence tells us, harms those things.
Absolutely. Totally agree.
Peter, thank you very much for joining us. And that article by Peter, Revolving Doors, Board Memberships, Hedge Funds, and the FDA Chiefs Responsible for Regulating Industry, is available on bmj.com, and the links are available from the podcast page. That's it for this week. We'll be back in a fortnight. Subscribe to us wherever you listen to podcasts. Until then, I'm Cameron Abassi. Thanks for listening.